Okay, I will start off while we're collecting. Dr. Sullivan, should we give all parturients a labor epidural to prevent postpartum depression?
There is an association, but not a cause and effect relationship established there. But clearly the implication is if evidence develops of more of a causal relationship, it clearly could affect our business.
Okay.
It could clearly affect how we look at other forms of analgesia, including nitrous oxide, remifentanil options, other non-neuraxial anesthetic options.
So, Dr. Hess, I was impressed where you do the simulation, but I find it increasingly hard to create time to do simulation and not do inpatient care. How do you solve that problem?
Yeah, so when we first started it, the first few, we were using people outside of the work environment. We realized that that was completely unsustainable. And so we actually use everyone who's on that day. The patient is a nurse or a medical student or a resident rotating on labor and delivery or something. The staff are the staff who are working that day. Most centers, there's time when there's variation. It's very busy, sometimes it's not very busy. And you take those times when it's not very busy, you can do one of these. The entire process of doing a simulation takes about 20 to 30 minutes. It's not a very time-consuming thing. So you can usually find in every center 30 minutes where you can devote to this process for the payoff in the end.
Okay, sounds good. Dr. Sullivan, you mentioned epidural fever in passing today. You talked about this subject and possible adverse neonatal outcomes at this meeting 2 years ago. Any updates?
Say that second part again.
You talked about this subject and possible adverse neonatal outcomes with epidural fever. Any updates on epidural fever?
Oh, I probably couldn't give you a very thoughtful one based on, it appears that there's a subset of patients that seem to be at risk for developing fever who have epidural analgesia, that it appears to be a non-infectious etiology, that it's related to inflammation. That was the context that I brought it up in. I brought it up that there is some evidence that of both an inflammatory and an anti-inflammatory effect of neuraxial anesthesia, and I don't think we understand it that well. I'll leave it at that.
Yeah, and I agree. There's a certain subset, like you said, that they're just inclined to epidural fever. So I'll read one for myself, so get me involved. It's Dr. Vallejo, do you think there should be a mechanism for physicians to seek mental health support at no cost? Absolutely. So one of the things that we're trying to do is we're trying to get our medical school or to get a social support person. So you get like a social worker or something that can basically lead it. And not that you have to go see that person, but at least it can structure that. And if you need to go see that person, you can go see that person. You can have an evaluation, sort of like internal medicine does, or there's a list of people that you can potentially see. And what was funny is we approached the medical school, and it went as high as up to the multiple departments, like the School of Medicine, the School of Nursing, School of Dentistry, and the AMCAS came, and they had to make more like medical student lounges. And the thing they said is, well, why should we give you a social work person to work on this when we already like upgraded your faculty or your medical student lounges, and the dental school, nursing school, and pharmacy school didn't get anything. So it got as petty as that. But really what they recommend is just have one person that's able to oversee it, and then you could see that person. And then the second part is many physicians have very high costs for medical insurance, high deductibles. Cost could be a barrier. Yes, absolutely. And it could be, and that's why they're doing that physical wellness, trying to get your blood pressure down and your cholesterol and your glucose. So I definitely see that. Okay, let's get Dr. Sullivan. In the DING study, did they control for socioeconomic differences between the parturients?
There was an evaluation of that, and I didn't get into the data, but clearly there's some additional information that be gleaned from there. Some of the things that we know about education levels, socioeconomic stat. I think the one piece of it maybe that I presented to you, the likelihood of attending a childbirth class, you know that that is stratified by socioeconomic dynamics, just being you have the time to do something like that.
Okay. Dr. Hess mentioned a patient with a crit of 40%. ABGs and CBCs were probably followed intra-op. So it shows how misleading a CBC could be. How does the panel interpret the CBC in a trauma like bleeding, like a bleeding cesarean section?
Yeah, it can be very challenging, especially if your lab isn't keeping up with what you're doing. And that's one of the problems that we all run into. Is I had a patient recently that I had to send off 3 sets of labs because they kept saying, we haven't received it, we haven't received it. And then I got all 3 sets back at the same time. So I think it can be very challenging at times for us to interpret that data. And that's exactly one of the issues. It's a limitation of what we're actually trying to do, right? So I don't have any major suggestions other than to say this is one of the difficulties that we have in doing our job, and we need better resources for figuring out how to manage our cases.
Yeah, yeah, you get the trends, get multiple CBCs, that'll definitely help you, because sometimes it definitely delays and you need to catch up, and the data, it falls behind. Dr. Sullivan, is there data for postpartum depression rates prior to the routine use of labor epidural analgesia? If so, how do they compare?
Yeah, I think it's one of the things that dawned on me reviewing this body of literature is that, like we thought about for the institution of labor epidural programs, there were these sentinel studies where a program went from no epidurals to 70% overnight, and that kind of informed us about this non-causal effect of labor analgesia and cesarean delivery. I think there's clearly some opportunities out there to make comparisons. Ultimately, nothing answers questions like a randomized controlled trial, but there's almost no places in the world where you can either ethically conduct a study like that or find a population that's so ambivalent about labor analgesia that they'd be willing to be randomized. That's essentially what you might need to answer that question. Clearly, some studies in the last 20 years have randomized people to epidurals, and there's still places in the world you can do that. It's not going to be done in any of our centers, though.
Okay. This is for Dr. Hess and Dr. Sullivan, both of you. What are some of your favorite go-to tricks for optimizing a suboptimal spinal during a cesarean section?
Well,
yeah. Go ahead.
Yeah, your favorite tricks. Well, I'll say this. I think a lot of people use gravity with a hyperbaric solution. I think the evidence on the impact of gravity is fairly limited. It does seem to influence speed of onset, but in terms of peak cephalad level, if you randomize someone to sit up for their spinal for 5 minutes after you place it versus lying them down immediately, you get the same peak cephalad level, which gives you some information to what degree that affects peak sensory levels. So gravity maybe is one that we overestimate its benefits. I think many of our tricks probably in terms of using adjuvants or systemic medications to augment are now being challenged to some degree by a lot of the science and discussions around the developing brain, certainly until the baby is out. We're being squeezed between several competing interests, and I also mentioned, the more systemic opioids you use, the more it's going to impact breastfeeding success, which has really meaningful, measurable public health benefits. It's a very difficult risk-benefit for us right now.
Yeah, my spinals never fail.
Yeah.
No. Yeah, I mean, put the patient on their head for cephalad spread is my first go-to. Sometimes it works, sometimes it doesn't. I think the bigger challenge is, because if it's at the beginning of the case, you can always roll them on their side and do an epidural to try to promote anesthesia. In the middle of the case, when their spinal seems to be either regressing or incomplete, but the belly's already open and the baby's being worked on, I think that's the biggest challenge. And I agree that even the FDA has come out to say that our medications may pose some risk, but I think safety of mom in that situation is paramount. And so, you have to make the decision between giving general anesthetic in the middle of the case, depending on mom's habitus, airway, et cetera, versus giving some intravenous supplementation. And for that, my preference is propofol, so Madaz propofol, versus some other colleagues use ketamine. But I had, as with anecdotes, I had a couple patients with bad trips with ketamine, so I tend not to use it in awake patients.
I think Phil and I and one of our colleagues here who had a discussion after a lecture yesterday about this very topic, breakthrough pain, spinal for cesarean delivery in the setting of extroversion of the uterus. And I think to some degree the conversation steered into really thoughtful decision-making about choosing an appropriate dose for bupivacaine, choosing doses that have been studied and consistently prevent breakthrough pain with limited risks of high spinals.
Okay, thank you. This will be the last question, and then we'll go ahead and have a coffee break. This is for Dr. Sullivan. Natural childbirth moms are self-critical, highly driven, and have high-driven expectations. They request less analgesia or no analgesia or no medications. Are they a setup for postpartum depression?
It seems like profound stereotyping. But there's probably some elements of truth in it, aren't there? This is a different patient population. I certainly think so in the US population. I've had some limited experience in clinical settings in China, but I think if anything, I thought that there was more similarities there than not between our populations. But clearly there are some differences in their systems that should be interpreted in terms of that DING paper. Unquestionably, there is selection bias in non-randomized trials. These are different patients with different expectations, and we know that their satisfaction scores, and we touched on it yesterday, they're often dissatisfied with zero pain, right? So pain doesn't correlate with satisfaction. It inversely correlates in some respects. It'll be interesting to see how this pans out. I don't really know where that science is going to go.
Okay. Well, thank you. If you have questions individually, come on up. We'll break now for coffee break, and we will see you at, I believe it's 10 o'clock.